Thank you so much, everybody, for attending Nephrology Grand Rounds and for attending our presentation from Seattle Children's Hospital. I will be co-presenting with several of the Seattle Children's Hospital Pediatric Nephrology Fellows today, and our first case will be in conjunction with Dr. Kelsey Alexander.
Hi, everyone. My name is Kelsey. I'm one of the first-year Peds Nephrology Fellows, and like Robin said, I'm going to kick off our first case. So we have KN. She is a 20-year-old female who has a history of Sjogren and lupus overlap syndrome. That was diagnosed when she was 9 years old, and she's now presenting to nephrology clinic with new onset proteinuria. This was discovered on a routine screening that was performed by her rheumatologist. During this time, she has also had some progression of her rheumatologic symptoms over the past 6 months or so. This has included new onset memory loss, brain fog, decreased concentration concerning for CNS lupus. She also has pretty severe eye disease and has had an advancement of that with increased plaques on exam with her ophthalmologist. She's had worsening pulmonary function tests and persistent leukopenia. When you see her, you learn that she has never had proteinuria or hematuria, and she's never had hypertension either since her diagnosis. Her review of systems has been negative for gross hematuria, edema, headaches, or abdominal pain. A little bit more about her rheumatologic history. Her lupus was diagnosed with a positive ANA and positive RNP and Smith antibodies. She has had normal complement levels since diagnosis. Those have never changed. At the time of diagnosis of her lupus, she had primary symptoms of arthritis, mucocutaneous disease, and then has had pretty significant hematologic involvement, including recurrent lymphopenias. And then over the 10 years or so of her lupus, she's had recurrent disease flares that have included recurrent joint pain, intermittent rash, and then persistence of this leukopenia. Her Sjogren has manifested with pretty severe eye disease. She has filamentary keratitis that she receives treatment for. And then her serologies were a positive anti-SSA and SSB at diagnosis. She also has a history of macrophage activation syndrome that occurred around the time of her diagnosis about 10 years ago. When you see her, when we saw her, the medications that she was on included 2 ointments for her eye disease, tacrolimus and cyclosporin. She was taking hydroxychloroquine daily, MMF, and then she's on a fish oil and vitamin D supplement. She does have a history of renal disease in her paternal grandfather, although the etiology of that is unknown. On exam, nothing really crazy. Her blood pressure was a little bit elevated, but that is not the trend that she has had in prior clinic visits. No periorbital or peripheral edema, and the rest of her exam was normal, including no joint swelling or new rashes. On the right here, we have her initial UA that ended up getting her sent to us, which included the 3+ protein, and then when quantified, a UPC of 1.8. Other blood work that was done at that time included a creatinine of 0.5, normal complements, a mildly elevated ESR, which has been normal for her baseline. She has a low white count at 2.4. And then she did not have an albumin done with her January labs, but the month prior, it was normal at 4.4. And so at this time, I think just in the interest of time, I'll go through our differential, but you can think about what your differential for this patient might be. For us, top of the list was orthostatic proteinuria, just because this was a teenager who got her first UA at like 5 p.m. And she's never had proteinuria before, so wanting to make sure it wasn't that. Tubulointerstitial nephritis because of its relationship to Sjogren syndrome. And then with the level of protein that she was having, wanting to consider glomerular disease, especially with her significant rheumatologic history. I don't know if you can click forward, Robin.
Oh, thank you.
Oh. And so our plan after seeing her was to first and foremost get a first morning void. And then with that urine sample, also get a beta-2 microglobulin to look for tubular protein. And if the repeat UA and UPC were positive for protein, consider moving forward with a biopsy at that point. And so, like most teenagers, it took a couple of shots to get the first morning void. On the first UA that we got after that clinic visit, it was in the afternoon, but she did show significant proteinuria. Around the same time, we were able to get a beta-2 microglobulin that was normal at 147. And then finally in March, we were able to get a first morning void, which did show non-orthostatic proteinuria with a UPC of 1.41. And so at that point, we decided to move forward with getting a biopsy. And so that's where I'll turn it over to Robin.
Thank you. So this, as always, I'm going to start off by showing you kind of an overview, low magnification trichrome image to give you just kind of a 20,000-foot view of how the kidney looked at biopsy. This was a generous sample. We had 97 glomeruli to look at. You can see that they're pretty densely packed. And you can see that overall, this is a kidney sample that has really well-preserved cortex where the tubules look good, the interstitium looks good. There's not much going on in the tubulointerstitium. All the action here is in the glomeruli, but actually there's not a ton of action in the glomeruli either. This is a representative image of some of the glomeruli, and by light microscopy, they look pretty normal. This is a very high magnification image of a Jones stain of a glomerulus, and I just want you to admire the glomerular basement membranes here and give them a good look. The only abnormality we could find by light microscopy is if you go to very high magnification, this is a 60x image on trichrome, you can begin, to make out a little bit of trichrome red material deposited on what looks like maybe the outer loops of the glomerular basement membranes. But wow, you got to be looking really hard for it. And this is really the only thing that we saw by light microscopy. So I'm going to experiment with the annotation ability, and I wonder if you want to put a check mark next to a possible diagnosis at this point. All right, I see some check marks appearing. Yeah, so by light microscopy, we weren't quite sure, I wasn't quite sure what was going on, but fortunately our IF tends to come out about the same time as light microscopy. And so we were able to investigate this possibility. It looks like we've got a couple of selections of membranous nephropathy here. And this is what we saw by immunofluorescence microscopy. So you can see that in contrast to the light, which looked pretty normal, there is this kind of coarse granular immune complex deposition, which is happening on capillary loops, kind of following the pattern of following the contours of the glomerular basement membrane. It was very bright for IgG. There was some trace IgA, it's not negative. IgM was trace. It's rather bright and with a similar pattern for C3 and C1q, and then there was also a bit of C4 staining. So this was a pattern that certainly suggested possible membranous nephropathy, especially in the setting of the proteinuria. But and it's a little hard to tell whether these are subepithelial or subendothelial on immunofluorescence. So it was very helpful to then get our electron microscopy back. And you can see by electron microscopy, if we follow the contour of the glomerular basement membrane around, there are electron-dense deposits that are uniformly subepithelial. And in some places, you can see where there's some reactive glomerular basement membrane material kind of coming up between these deposits. So this is a pattern that, consistent with the IF, really looks like membranous nephropathy. Here's another image, again, showing that these are subepithelial deposits. There were no intramembranous deposits. There were no subendothelial deposits. Everything going on here was subepithelial. And concordant with that impression of proteinuria, we are seeing at least partial effacement of the podocyte foot processes and some microvillus transformation of those podocytes. And here's one more image showing again that microvillus transformation and again some subepi deposition. So what's your diagnosis now? Yeah, I think it's membranous nephropathy. So the sort of diagnostic question in this case was, this is membranous nephropathy, but given that this patient has a history of Sjogren lupus overlap syndrome, the question that we sort of engaged was, does this indicate lupus nephritis class 5, or is this a primary membranous nephropathy? And this paper describes the phenomenon of anti-PLA2R membranous nephropathy, sometimes associated with Sjogren syndrome. I think the thing that kind of supports this possibly being that rather than lupus class 5 is that there was sort of weak full house staining. So if you go back and you look at the immunofluorescence again, the IgA staining is trace, the IgM is trace. It's not the most robust. And then the other thing that I thought could perhaps support this not being lupus is that we've got deposits pretty much exclusively subepithelial. And it seems like in lupus, frequently there's at least some intramembranous or subendothelial deposition. So I raised that question in my report, and I will kick it back to Kelsey to talk about what happened next.
Thanks, Robin. So there were some clinical considerations that the team had after being presented with those two options from Robin. Robin, if you'll click forward a couple times. So when considering primary membranous, like Robin said, there was this weekly positive IF staining, but the team was also considering whether or not her treatment of lupus that had been ongoing for so long could have diminished the positivity on that IF staining. At the point of biopsy, we didn't have an anti-PLA2R antibody for her, and we still haven't gotten one, because one of the most important things about Kayan's clinical course is that at this time of biopsy, she also had a significant flare of her extrarenal lupus, and her eye disease was continuing to progress with just the topical treatment that she was getting. And so the team had decided that systemic tacrolimus was in her future, regardless of what ended up coming of the kidney biopsy. And because tacrolimus would address the lupus, they decided to move forward with that first. So if you'll click forward again. So that was the first step in her clinical course. Because she was going to be on systemic tacrolimus for her eyes, they decided to see if that would help address the proteinuria. She did have improvement in her proteinuria, but required increasing doses of tacrolimus to help control that, and achieved a level up to 10 before deciding to change course a little bit. The concern was the kidney injury that could happen with continued doses at that level. And so then just about 2 months ago, the decision was made with the family to move forward with rituximab, which would treat either primary membranous or lupus nephritis. And so that is why the team still has yet to get an anti-PLA2R antibody, because the endpoint is the same for this patient. So the rituximab has been planned, has not been done yet, but hopefully soon. And her proteinuria has improved significantly. Her last level was in December of this year at 0.5, which is prior to her rituximab treatment.
Thanks.
I think that's all.
Yeah. I see a question in the chat from Dr. Alpers, extraglomerular deposits by immunofluorescence. I don't think there were. I do not have a way of pulling up that report while I'm in the middle of the presentation.
They're there in the IgG.
Oh, okay. Well, let's go back and look. These here?
More at 5 o'clock. Yeah. And down below at C3, they match.
Yeah, I think that's an arterial. I'm not positive. I think you're right. And what does that signify for you?
Well, I don't know how widespread they were. I think it just makes the point that people don't always appreciate. You can get a fair amount of extraglomerular immune deposits in lupus, and you have no inflammation or real damage in the tubulointerstitium, as you showed at the outset, which I find very peculiar, a paradox that's never really resolved in my mind.
Yeah, that is interesting. Huh. And this is a case from last year where I think we still have the IF around. I'll have to go back and take a look and see kind of how extensive that is, because it's not something I think I was more focused on the glomeruli, but that's, yeah. No, thanks for pointing that out. All right. we are going to step on to the next case. I wanted to remind folks that if you want to use annotation in these presentations, you can click on View Options at the top of your screen and then click on Annotate. Let's see. I see two more questions. Does the C1q not make primary membranous nephropathy less likely? Yeah, I think the bright C1q is pretty supportive of lupus versus primary membranous nephropathy. Did you entertain EXT2 staining? It's not a stain we have in-house, and it's not one I have much experience with. Do you think I should, Kelly?
Sorry. Well, I mean, I think it would help if it was positive. It would help really support a treatment down the road of lupus membranous nephropathy. And it also could provide some prognostic information.
Okay. That is something that I will have to do some more learning about. Thank you for telling me about that. All right. Our next case is going to be presented by Dr. Lauren Hawkins.
Alrighty. So I'm Lauren Hawkins, one of the second-year pediatric nephrology fellows. This is a case of a 6-year-old at the time of presentation with history of end-stage kidney disease due to bilateral renal dysplasia, whose status post-transplant back in 2020, which is about 2 years prior to this presentation, who came in with hypertension. So some more about her medical history. We just discussed her transplant about 2 years ago. She had thymoglobulin induction and then continued on tacrolimus, as well as MMF initially, which was actually changed to azathioprine because of some difficult to control diarrhea. She also, because of her persistent DSAs, was maintained on prednisolone as well. Her initial course was complicated by a few viruses, so primary EBV and BK viremia, which were eventually resolved. And she had a workup for PTLD initially with the EBV that was negative. For the positive DSAs, she received our standard regimen, which includes rituximab and IVIG. Of note, she was found to have a cerebellar mass in 2021 and is status post BP shunt at that time. She had not had a biopsy of that lesion, but the cytology was negative on LP, and this was presumed to be a low-grade glioma.
And I think she did actually eventually get biopsied, and it did have molecular features and histologic features consistent with low-grade glioma.
Yep. Yes, we will not be reviewing brain tumor path today, but we could if we want to. So she presented from home because of high blood pressures measured by her caregiver at home, which on presentation was 160/100, which I know is high for any of you adult folks, but to highlight for a 6-year-old is quite elevated. Our typical target is less than the 90th percentile, which is 107/68 for this patient. She also had some chest pain on initial presentation. Her labs were notable for a creatinine really at baseline of 0.6. Albumin was slightly low at 3.5. And I've mostly highlighted here just the kind of abnormal or notable labs. So her hemoglobin was a bit low at 9.2, but CBC was otherwise normal. Her UA showed a few red blood cells, and of note had a urine protein to creatinine ratio that was quite a bit elevated compared to her baseline, which baseline had been normal, had not previously had proteinuria, so UPC at 3.16. Her C3 was normal. Her C4 was just slightly low at 14 with the lower limit normal of 15, I believe. And then her TACR level was a bit low at 2.7. As noted on the prior slide, she had many positive DSAs in 9 channels here at the time of presentation, which was similar to what she'd been dealing with without significant improvement with the rituximab and IVIG. Alrighty, we have a little bit of time, so if people want to write in the chat or talk out loud, what are some things on your differential diagnosis for this patient? Okay, I'll keep moving. Yeah, AMR definitely given her DSAs. And then her low TAC level as well. So we were concerned about rejection, in particular, antibody-mediated rejection. We considered angiotensin receptor antibodies, and those were pending at the initial workup, as well as infection given her history with viruses pending initially. Though of note, her recent labs for the past year or so had been negative with her viruses. Also considered medication effect with her hypertension, in particular tacro, but again, her tacro level was actually low. Also considered renovascular disease, which had not been an issue for her previously. And then sort of more kind of standard transplant glomerulopathy, as well as sort of other causes of AKI. Though again, that creatinine was really at her baseline of 0.6. All right, so our initial management was essentially getting her to a biopsy. We made some adjustments to her blood pressure regimen, including adding valsartan, in part for better control and in part because of that concern about the AT1R receptor antibodies potentially. We increased her tacro dose a little bit and sent her for a biopsy.
Yeah. So here's a low magnification image of her kidney biopsy. Which generally looks pretty okay from low magnification. There was some interstitial fibrosis and tubular atrophy, which you can see here, but in other areas, you can see that this is a well-preserved cortex. There's no significant inflammation or edema. There's a little bit of arterial intimal fibrosis, which we won't talk about much further here. However, on closer magnification, the glomeruli were uniformly and markedly abnormal. So you can see at this magnification that these glomerular basement membranes look diffusely thickened and remodeled. And you can also see that there's rather prominent endothelial cells that kind of pop out at you. Looking at higher magnification, you can see some clear areas where there's glomerular basement membrane duplication and double contours. And then again, endothelial cells that are rather prominent with occasional circulating inflammatory cells, but no endocapillary proliferation. This is what it looked like on PAS. Again, you can see this evidence of basement membrane remodeling that pretty much diffusely involved every glomerulus. And when we look for immune complex deposits on trichrome, which is the best light microscopic stain, there's like some sparse trichrome red material, but yeah, not very much. It was a little bit underwhelming. So our impression by light was just of this diffuse basement membrane remodeling. Of note, there was perhaps a touch of glomerulitis, as I showed, but no significant peritubular capillaritis. Here's the juiciest area of peritubular capillaries I could find in the biopsy, and you can see that there just aren't that many circulating inflammatory cells. And indeed, in many places, they're not very prominent at all. I show this because the C4D was diffusely positive. Our house C4D stain is not super strong. This is about as good as it ever gets. So there was a lot of C4D staining. By immunofluorescence microscopy, there was deposition of material, particularly of complements C3, C1q, and C4, but also of IgG, IgA, and IgM. The pattern for all of these was the same. It was finely granular material that was depositing along glomerular basement membranes. Brightest for C3 and C1q and C4. By electron microscopy, what we saw was this massive subendothelial electron dense deposition process with significant remodeling and sort of deposition of additional glomerular basement membrane material, again in a subendothelial pattern. There's partial effacement of the foot processes, although you can see in some areas they're actually relatively well preserved. This is a close-up showing one of those capillary loops from the previous image. Again, the outer contour of this basement membrane looks pretty well preserved. And indeed, the lamina densa looks good as well. But then in the subendothelial space, I think there is this kind of moderately electron dense deposition of material. And then there's also duplication and elaboration of additional glomerular basement membrane material. You can see these endothelial cells are large and prominent, and in this case, occluding this capillary loop. Just one more image showing a few more representative sections from electron microscopy. So this was diffuse glomerular basement membrane thickening with full house immune complex deposition, and then also this strong diffuse C4D staining in peritubular capillaries. And we commented on the presence of these prominent endothelial cells, but no significant proliferation, on marked basement membrane changes, and suggested that this might represent two concurrent processes. There seems to be an immune complex glomerulonephritis here. We wondered about de novo lupus. And there also was evidence of acute antibody-mediated rejection. And so we considered diagnoses including de novo lupus, another de novo immune complex glomerulonephritis, and we also suggested the possibility of a post-viral or viral-associated immune complex glomerulonephritis, such as a hepatitis-associated process. I'll send it back to Lauren.
All right. So this was not exactly the biopsy findings we were expecting for this patient. Before we had the sort of final path results, given our concern for the sort of proliferative process with C4D staining, indicating complement sort of fixation and activation with her DSAs. She was started on induction eculizumab with associated vaccines and penicillin prophylaxis. And then following kind of final biopsy results consistent with some version of de novo lupus nephritis, her azathioprine was stopped and replaced with MMF, which she luckily tolerated pretty well and was not having diarrhea at this time. Given that finding, we did a more extensive workup looking for lupus. All of it was negative, including ANA and the ENA panel as well. Her viruses were negative. I didn't include this here, but her hepatitis B and C labs had been negative as well for any active or prior infection. Her CH50 and soluble C5b9 were all normal. And her C4 actually subsequently normalized and has remained so. So it's a little unclear if that slightly low C4 was ever kind of truly real or just one spurious lab. Her AT1R antibody was positive at 40 units per milliliter. So there's a question in the chat about, would we get, is that standard to get in the setting of antibody-mediated rejection, especially knowing how high her DSAs were? I think it's not standard for us to necessarily draw it or look for it. I think we were concerned about the degree of her hypertension and that she had had positive DSAs for quite a while and had this new hypertension. And so we worked her up with some more investigation than we might otherwise. But ultimately, this didn't really change our management for her. We also reached out to UNOS to learn about the mate kidney from her donor and found that they had no concern for lupus or other dysfunction in that kidney or in that recipient. So post-biopsy, just some more updates for her. She was eventually able to go home with improved blood pressure on a 3-drug regimen, which were later able to be weaned and I believe is off clonidine now. She was transitioned to ravulizumab, which is not something standard for us, but given her ongoing positive DSAs without sort of prior response to our standard treatment with IVIG and rituximab. That's why she started on that and is maintained on it. She has also continued to receive IVIG, also for those positive DSAs, as well as some low IgG levels. And her UPC improved significantly and has remained normal to only slightly elevated. And her creatinine really this whole time has remained normal, or at her baseline rather, from 0.5 to 0.7. Here are her DSAs just a few months after this presentation and after initiation of ravulizumab, or rather eculizumab, and maybe 1 dose of ravulizumab at this time. So going from 9 channels to 6 channels at this point. There's a question in the chat about sort of ABO compatibility for this transplant. I don't know. I think pretty rarely do ABO incompatible transplants, but I'd have to look back. And then a year later, we pursued another biopsy, I believe just sort of as follow-up, given the sort of atypical findings on the primary biopsy. So here we go.
Yeah. So in this follow-up biopsy, at low magnification, we again had fairly well-preserved cortex with about 40% interstitial fibrosis, tubular atrophy. Here's a bit of it in this image. By light microscopy, the glomeruli had a similar appearance in many ways to the biopsy from a year prior, where there was some evidence of continued basement membrane remodeling and duplication. You can see some double contours here, as well as just areas where the basement membrane looks irregular and remodeled. The endothelial cells were still quite prominent. Here's another image showing, again, evidence of remodeling, duplication, double contour formation. And then there were now some rare areas where there was segmental endocapillary proliferation, and this is an example right here. That was not present previously, and it was now present in a few glomeruli. There was now more prominent mild peritubular capillaritis, which I'm showing here, but it's not super impressive. And the C4D continued to be diffusely positive. The immunofluorescence was interesting in this follow-up biopsy. We continued to have full house staining, although IgA was now just a trace. But in contrast to the prior biopsy, that staining was now segmental within most glomeruli rather than global. So you can see, and overall it was a little bit less bright and a little bit more variable. So you can see IgG staining, IgM staining, and then C3, C1q, C4, all were showing this kind of segmental glomerular basement membrane staining pattern. And I'm just gonna, there was none available for EM, so I can't show you follow-up EM, but I just wanted to contrast the immunofluorescent appearance on the first biopsy to that of the second biopsy to again show how segmental the staining had become. And it's possible that that represents treatment effect or just evolution of the disease. So this is a membranoproliferative glomerulonephritis that continues to have a full house staining pattern. And it's got this diffuse C4D peritubular capillary staining with some mild glomerulitis and peritubular capillaritis. And so we engage, as I said, similar findings to before with maybe a little bit of evolution. Looked like possible de novo lupus nephritis given that staining pattern. One question that we engaged with is, what's the significance of the C4D staining? So C4D staining is not always equivalent to antibody-mediated rejection. And in particular, if you look at C4D staining in the setting of lupus nephritis, and here's a paper about it, C4D is positive in up to 1/3 of lupus cases, depending on what series you look at. And we also considered the possibility that our glomerulitis and peritubular capillaritis could be attributable to the presence of glomerulonephritis. So while all of these findings could be suggestive of antibody-mediated rejection, it's also possible that they could be attributed to other processes going on in this kidney. So yeah, do you have follow-up on what's happened to her since then, Lauren?
I do, and there may be a few more slides, but I can also just share if you don't have them there. Oh, no worries. I'll just get some updates. So she got a round of similar treatment. So she continued on rituximab, IVIG, and ravulizumab, primarily for the ongoing positive DSAs. And as you said, this sort of question mark AMR picture. However, we knew that that treatment would hopefully help with whatever sort of antibody process as well as complement mediated process. And then, as you mentioned earlier, she around that time underwent biopsy and laser ablation of her tumor, which is unrelated to her kidneys, but just added some added complexity to her course. At this point, her DSAs have actually continued to decrease, so they're only positive in 4 channels. And her creatinine, again, has remained normal, as has her UPC and her viruses. So she's overall doing well and is responding to sort of a lupus or lupus-like treatment.
I see a couple of comments in the chat. So Dr. Najafian says, immunofluorescence helps to differentiate C4D staining in peritubular capillaries due to lupus versus AMR. The C4D staining on IF in lupus is granular. Oh, that's interesting. And different from AMR. Okay. We don't do immunofluorescence for our C4D, but that could be a reason to consider it and maybe send it out to you all in some settings. There's a question, ANA negative SLE question mark.
Right, which actually we were just talking in our fellows didactics about how that's not really a thing. So I think my understanding is that de novo lupus nephritis status post kidney transplant is certainly described in the literature, though really only in case reports, and it isn't necessarily associated with serologies that are consistent with lupus or systemic symptoms, which she hasn't had at all. So I think we are still calling it that based on these findings, which is similar to what's reported in the literature. But you're correct that it's sort of not quite a typical picture given that she was ANA negative.
There's one more question in the chat, but we are short on time, and I want to go ahead and make sure that we have time to talk about our third case. So I'm going to go ahead and tee up Dr. Caroline Jackson to talk about the third case.
If anybody needs to leave, we run over a couple.
Caroline, you're very soft. Can you find a way to make it louder? Can't hear you.
How's that? Better?
That's better. Yes, thank you.
Better. Okay, great. Thank you. Great. All right. So if anybody needs to leave, that's totally fine. This is kind of a mystery case anyway, but we would love some thoughts and impressions. So this is about a 4-year-old female who had end-stage kidney disease from an obstructive uropathy and neurogenic bladder in infancy. She got her deceased donor kidney transplant with bilateral nephrectomies at that time, about 3 months prior to this presentation, where she comes in with an elevated creatinine. Important medical history. She had a tethered cord and Chiari-1 malformation. That's what led to her obstructive uropathy, neurogenic bladder. She also had some reflux nephropathy in that setting, had a vesicostomy when she was a baby, but ended up in with progressive renal dysfunction and was on peritoneal dialysis starting at about 1.5 years of age. Her course was a bit complicated. At age 2, she had a pretty severe fungal peritonitis that required a very prolonged hospital stay. And then and a changing of her modalities and catheter. And then at age 3, she was very sick with a polymicrobial peritonitis, which caused endocarditis, septic shock, septic pulmonary emboli. She actually was on VA ECMO with CRRT for a very long time. But eventually after that critically ill incident, did get back on PD and was home. And then at age 4, which was about 9 months after that critical illness, she got her deceased donor kidney transplant and her nephrectomies. So she comes in to us for this case with mostly just after some routine labs. These were just routine monitoring labs. It's 2 months after her transplant at this time, and her creatinine's up at 0.9 from her baseline that had been about 0.3, 0.4. You can also see she's got a bump in her BUN, a little bit of an acidosis. Her TACRO was a little low from her goal of 7 to 10, but that was in the setting of it recently being very high. And so they were adjusting her dosing. Her DSAs were negative and had been throughout thus far, and all of her viruses were also negative. So we bring her in overnight. We're saying considering a biopsy in the morning, but we give her some IV hydration. Her labs get a little bit better. We had that history of a recent high TACRO level, and so we didn't think too much of it. Her ultrasound was also reassuring. And so we actually decided not to do the biopsy and discharged her home. We were just going to follow up closely outpatient and improve her hydration. However, 3 days later on some follow-up labs, her creatinine was continuing to worsen up to 1.2, continued elevated BUN. Her potassium was starting to climb a little bit, and then still acidotic. TACRO is still on the lower end, but this time also she has volume overload. She's noticed to have some ascites and is hypertensive, so we bring her in and we do get a biopsy.
So at low magnification, this biopsy looks markedly abnormal. You can see the presence of interstitial hemorrhage, as well as edema and a lot of inflammation. There was a brisk mononuclear interstitial inflammation that you can see present here, and you can get a little hint of what's to come here in this artery. Looking more closely, there were many arteries in this renal biopsy that had arteritis with mononuclear infiltrates in the intima, and then this intimal expansion that in some arteries was at least focally completely occlusive, and you can see many mononuclear cells both under the endothelium and in this neointima. Additionally, there were several arteries that demonstrated frank fibrinoid necrosis, which certainly could account for some of the interstitial hemorrhage that we were seeing. So this is an example of one. And then here's another one here. In addition to that arterial fibrinoid necrosis, there are focal areas of cortical and tubular necrosis. This is a tubule here that is necrotic, and there were other foci kind of scattered throughout the kidney. However, the glomeruli, for the most part, look pretty normal. These are representative glomeruli. Of the 35 glomeruli we had to look at, there was, however, one that looked like this. So in this trichrome stain, you can see that many of these capillary loops are quite congested. And then within this kind of central hilar area, there is a fibrin thrombus. And this is what it looked like on the Jones stain. So my question for you, and you can annotate this, is what grade of T-cell mediated rejection would you give this kidney? So we've got arteritis with occlusion of the intima and also areas of arterial fibrinoid necrosis. And once you've got either transmural arterial inflammation or fibrinoid necrosis, yeah, you are in grade 3 T-cell mediated rejection. Yep, thank you. And Dr. Leka says maximal. Yes, I agree. So that's what we called this. And we also noted the presence of thrombotic microangiopathy in one glomerulus.
And so that was pretty severe findings on that biopsy. We also thought it was a little bit interesting to see these interstitial hemorrhages, which we don't see very often. And so I'd love to hear people's thoughts on that, or if they've seen that in this setting where we have this rejection. Maybe just throw some things in the chat and we can talk about it at the end as we go through. But we were also like, okay, what additional workup should we do to investigate that? What's our treatment plan? And go ahead, Robin. But what we decided to do for a little bit additional workup is we got another renal ultrasound. Also looked pretty similar, but when they were doing that ultrasound, they noticed that there was increase in her ascites as well. And so when they were doing the biopsy, they did a paracentesis, and they made sure that wasn't urine from a urine leak. It was not. And then ran some infectious workup on that because she did have this history of fungal infection and then also polymicrobial infections in the past. But that also was negative. As you can see, as her hospital stay progresses, her creatinine continues to climb. We're fiddling with her TACRO levels and they're kind of jumping all over the place. You can see that. And things are getting worse. What we did for this initial management, she got methylpred pulse, she got thymoglobulin 5 doses, and then after that treatment was completed in the setting of her continuing to progress, we got another biopsy.
And that second biopsy was, I think, 2 weeks after the first one. Is that right? Ballpark?
Yeah, like 10 days.
Yeah. So in this biopsy, again, it was a generous biopsy. And again, we continued to see interstitial edema and extensive hemorrhage that you could see on low magnification here. One of the changes in this biopsy was that there were now large areas of cortical, just frank necrosis involving a third of the sample in several cores. So you can see here that we've got relatively well-preserved cortex, and over here we've got a loss of the blue staining in nuclei, so this is necrosis. We did see a resolution of the interstitial inflammation we'd seen previously, so it looked as though there was some interval change reflecting treatment for rejection. There was resolution of the tubulitis with now like tubular repair, and there was resolution of the arteritis as well. However, you can see that there's now something new going on in this glomerulus and in these glomeruli, where these glomeruli have congested capillary loops and then have large occlusive fibrin thrombi within capillary loops, or in this case, within the arteriole and hilum. And then in some, you could see early evidence of glomerular basement membrane remodeling. So what's the process going on in these glomeruli? What would you characterize this glomerular process as? So this is an example of acute thrombotic microangiopathy, and it was involving virtually all of the glomeruli. I think like 90% of the gloms in this sample were involved. And then we also saw a small amount of continued arterial fibrinoid necrosis, and then here's an example of that, probably reflecting, again, that resolving severe acute rejection. So this biopsy showed diffuse acute thrombotic microangiopathy, cortical necrosis and interstitial hemorrhage, and then resolving rejection.
All right, so that was another surprise for us. So we see some improvement in the thing that we knew about, but a whole new problem. And already things were starting to go through our mind about what was that from? Is this a separate problem, or is it because of the severity of the rejection? But so regardless, we moved forward with treatment. She got eculizumab ×3, as well as plasmapheresis. She'd get the pheresis and then get the eculizumab after that. And then also we transitioned her from tacrolimus to a everolimus combination to try to adjust her immunosuppression a little bit and lower the tacro level. And then she continued on her MMF and her prednisolone taper after her pulse. We did a little bit of additional workup looking at things that could have caused atypical HUS. And all of her complement mediated labs were totally normal. So that was interesting as well in the setting of such severe TMA. But her kidney function continues to decline. She ends up with pretty severe volume overload. We're not able to provide her. She eats through a G tube, enough liquid nutrition. And so she ended up actually having to go to the PICU for CRRT.
Dr. Alpers asks, did you do routine IF studies on the biopsies? Is this an antibody-mediated vasculopathy? We did do IF on the second biopsy, and it was negative. Yeah, thanks for asking that.
And so this is her hospital admission continuing. We finish up those treatments that I talked about. She does improve and is able to come off of renal replacement therapy. Her creatinine is now 1.4, 1.6. Remember, her baseline was 0.3, 0.4, but much better than being on dialysis. And then a couple of days later, the family has a very important family event, and they're really adamant that they need to go to this. And so she actually discharges from the hospital with plan for daily labs at an outside facility that's out of state. We get a call from this outside facility about 5 days later, and the patient is in the emergency department with severe bradycardia, increased work of breathing. She's very sick. Rising creatinine, her potassium is 9.2, and she's admitted to their PICU and started on CRRT there. Move forward a little bit, Robin. And then, so they stabilize her there, transfer her back to our PICU, where she, at that point, is able to get by with intermittent hemodialysis instead of CRRT. We give her a little bit more eculizumab. We transition her immunosuppression some more with this time cyclosporin, everolimus, and she's on prednisone, and we stop the tacro and the MMF completely. And then we get another biopsy after all of this. And this is now about only a month from the first biopsy. So this is her third biopsy.
Yeah, so so this biopsy was again adequate. It again showed this extensive interstitial hemorrhage. And now, in contrast to the previous biopsy where we saw cortical necrosis in about 1/3 of the sample, it was now present widespread in about 2/3 of the sample. You can see that in this H&E image. We continued to see thrombotic microangiopathy, now with kind of more chronicity, so more evidence of glomerular basement membrane remodeling than previously, which makes sense just given the time period. Here's another example of a glomerulus that shows significant basement membrane remodeling, as well as some areas of mesangiolisis. And then the new finding here was that we saw significant arterial intimal fibrosis that in many fields was completely occlusive. So in this trichrome image, you can see here's a small artery arteriole, and then there's this area where it's the lumen is distended and completely occluded by this fibrous material. Here's another example. And in this case, this is a little bit of endothelium, but the lumen is completely occluded, and you can see mononuclear inflammatory cells within this neointima. So this meets the criteria for chronic active T-cell mediated rejection, and is a significant arteriopathy that we saw in numerous arteries in this biopsy. So she had continued thrombotic microangiopathy, now more extensive necrosis, and then this severe diffuse arteriolopathy with and still a little bit of focal fibrinoid necrosis. So yeah.
Yeah, so still quite sick. And I'm trying to look in her chart right now because I don't want to, about her antiphospholipid antibody status. I feel like if that was positive, I would know, but I'm having trouble pulling it up to confirm that. Maybe one of the attendings on the line knows. But so basically with these new findings, we kind of did a bunch more treatments. We gave her 5 additional plasmapheresis sessions, as well as putting her on chronic eculizumab that she's getting every 2 weeks. She received rituximab and IVIG. We consulted genetics to see if there was a genetic component. She's since had a whole exome and mitochondrial testing that is negative for anything pertinent to this. We asked the liver doctors because of her ascites and some other things if she could have had a TMA in her liver that they did not feel was present. We checked in on the paired kidney, not having similar problems to this. So, but she received these treatments. We continued dialysis for a few days. She did progressively get a little bit better after all these interventions. And then I think she was able to discharge home after a very long hospital stay. And now her creatinine is stable at 1.6, 1.8. She's still at home. It's been about 3 months since this time, and she continues to receive eculizumab outpatient. And her creatinine is holding about where it is right there.
Yeah, and my recollection after that third biopsy was I was saying things like, "My God, she's knocked off 2/3 of her kidney. This is terrible." And you all were saying, "Yeah, but her creatinine is not all that bad. Maybe it's not representative." And the fact that her creatinine has now stabilized at a really elevated level, but it's stabilized, suggests perhaps that perhaps that 2/3 of cortical necrosis is not representative of her entire graft kidney.
Possibly. She certainly is doing better. We also wondered if there was actually some antibody-mediated rejection that to a non-HLA antibody that we just weren't able to. We did her ATR1 and that was negative, but because she didn't seem to respond to that first treatment where we really treated the acute cellular problems, and then things just got worse with the TMA. And but then after we used the rituximab IVIG, these other sessions, maybe we were actually treating something a little bit differently there that we weren't sure. I see in the chat about the TMA was found in the second biopsy. Yes, we changed her immunosuppression to be an everolimus tacrolimus combination then, and then further switched to the cyclosporin plan later. This was like a very much evolving process, but would love to hear thoughts. This is atypical for us. Were you concerned about everolimus in the setting of this much injury, possibly delaying healing? Yes. Yeah, we had many discussions about that, and we're trying to decide. In the time when we were still trying to figure out what the TMA was caused by, we couldn't decide, was it this severe rejection or could it have been even tacrolimus induced? So it's tricky. Yeah. Oh, I have confirmation from one of the attendings that the APLA was negative.
It was negative. Okay.
Yeah.
And Dr. Najafian's asked, how was the status of the vascular anastomosis of the graft?
No concerns on any of the imaging that we did with her renal indices. At the beginning, they were a little abnormal, but by the time that she presented, they actually were looking better. Has anyone seen anything similar to this in the past where they've had a TMA presentation after severe rejection? And looking back, we had that one glomeruli with TMA on the very first biopsy that we didn't think that much of at the time.
And it was one out of a very large number of glomeruli, so it's peculiar. And I feel like, sometimes TMA can be kind of subtle, or sometimes it can be only focally involving glomeruli. This was just like the most raging TMA ever, so it was peculiar from that standpoint. Calcineurin inhibitors are known to cause thrombotic microangiopathy, but this just seems so severe. It was really surprising.
Oh, yes. Another good question about avoiding the CNI and mTOR altogether. It was challenging because of that balance where she did have the cellular rejection as well. And we were concerned that maybe there was antibody rejection we couldn't see based on the biopsy findings. So we did think about it, but then ultimately it felt like it wasn't safe to completely take off her immunosuppression. What my attending is letting me know too about the mTOR, when we were thinking about when we made that first switch, we felt like she needed immunosuppression, but we also wanted to decrease the TACRA. So that's where the mTOR came in, even with the risk of wound healing problems.
Yeah, and Dr. Alpers says, very atypical. I think that if this was antibody induced, you might only catch it on the first biopsy. The path picture looks like what used to be recognized as hyperacute rejection. Yeah, but chronology is a bit off. Yeah, this was 2.5 months post transplant. Yeah. And
Yeah,
and
very
she
strange.
and her initial, like, immediately after transplant, she had good graft function. Is that correct?
Yeah, excellent graft
Huh.
function immediately
Yeah.
after. Yes. And going back through her chronic medical history, she has had a very complicated course with some very severe infections and complications that multiple times we have asked immunology, do we think there's something unique about this child that she's so susceptible? Or is it just all of her chronic illnesses? Because I mean, she was on ECMO for a very long time with many
That's right.
infections, and that was not the first time. So but all of her workup for those sorts of things has been negative. So we just wondered if her immune system acted a little different than everybody else's. And maybe that's why we saw the timeline a little different for this hyperacute rejection. But I don't know if we'll ever know.
Yeah.
Yes, she was able to do PD despite having a fungal peritonitis later after that. And part of that is because this patient lives in Alaska. And so with family and other siblings. And so it was a strong goal of the family to be able to get back onto PD, even though it took a long time to wait for her peritoneum to heal. Granted, at the point of this transplant, she was like this close to having peritoneal failure. She was on all reds or high dextrose bags, and so it was just in the nick of time, because I don't know that we would have been able to keep doing it from a distance. But there is no availability for pediatric hemodialysis in Alaska, so the whole family would have had to move to Seattle.
Maybe just one more question from Dr. Ng in the chat.
Yeah. The final
Oh,
question is, what would you do differently if she would need another transplant?
that is a great question. Perhaps closer monitoring and earlier biopsies to see what goes on. She seems to be doing okay on this cocktail of immunosuppression. And so thinking about that, but I mean, she got a ton of thymo, and she got 5 thymo right after this transplant, all of those things. So I don't know. Someone wiser than me should weigh in on that.
It's worrisome, because it's hard to imagine this kidney making it to adulthood.
Yes.
Yeah.
So that will come up.
Yeah. All right.
Oh,
Well,
my attending says TPE then eculizumab. That's what he would do. So there we know. He knows, because it probably will come up either for us or for you. So something to be thinking
that's
about.
Everything, all the medications.
Yes,
Well,
and immunology from the beginning.
right, truly. Well, seriously complex pediatric cases. Thank you so much to Dr. Reed and discussants.